Hello everyone, good evening. Dr. Monday is here again. So today's discussion is about pheochromocytoma. Alright, so what are we going to talk about? We're going to define pheochromocytoma. We would look at the signs and symptoms. How do we diagnose pheochromocytoma and treatment? And also I'll discuss some miscellaneous stuff that you need to know about pheochromocytoma. So, what is pheochromocytoma? Pheochromocytoma is a rare catecholamine secreting tumor that may precipitate life-threatening hypertension. Basically, what am I saying is that in pheochromocytoma, there is release in catecholamines. And what are catecholamines? We're talking about our epinephrine and norepinephrine. Now, for pheochromocytoma, the majority of it comes from the adrenal gland. 90% of pheochromocytomas are located within the adrenal gland and 98% are located within the abdomen. Now, when pheochromocytomas arise outside the adrenal gland, actually it's no longer referred to as pheochromocytoma, rather they're called extra-adrenal pheochromocytoma or paragangliomas. So when you have tumors that are secreting catecholamines and they're outside of the adrenal medulla, right, then we call them extra-adrenal pheochromocytoma or paragangliomas. So what are the common locations of these paragangliomas? Well, one of them includes the organ of Zuckerland, which is very close to the bifurcation of the aorta. Now, another place where you can get pheochromocytomas include the bladder wall, the heart, the mediastinum, and also the carotid body. So all of those locations could also produce epinephrine and norepinephrine. So pheochromocytoma could be found with other syndromes like neurofibromatosis 1, von Hippel-Lindau syndrome, and MEN2A. And the mnemonic MPH there is telling you that in MEN2A you have medullary thyroid carcinoma, pheochromocytoma, of course the P, and hyperparathyroidism. I'm going to talk about MEN2 in another video lecture. Now also pheochromocytoma could be seen in MEN2B syndrome, where you have mucosal neuromas, medullary thyroid carcinoma, mafanoid body habitus, and of course the P again is pheochromocytoma. If you're familiar with MEN syndrome, you know we have three of them: MEN1, MEN2A, and 2B. So pheochromocytoma is seen in the MEN, just generally the MEN2s actually, both A and B. So pheochromocytoma has the rule of tens. So 10% could be familial, 10% of time it could be bilateral, and in this case you should suspect MEN2B syndrome. Now in 10% of the cases also it can be malignant. And 10% also it could be multiple, and also you could have 10% occurring in children, because again pheochromocytoma is really common in adults, but in 10% of 10 sometimes you can see it in children. And 10%, which we've established previously, is that it can be extra-adrenal, and the most common site is the organ of the pronunciation is mouthful, Zuckerland. Alright, so this slide here is just to refresh us on the biochemistry. So this slide is basically especially for those of us who are studying for step 1. So this is a good refresher for the pathway of norepinephrine. So make sure you review this in the first aid, especially to also know the cofactors that you need, in this pathway, because they're going to be tested on that. Alright, so now let's talk about, we said that pheochromocytoma, there is production of epinephrine and norepinephrine. So let's see how they work. So we're just going to do a little pharmacology. Now, norepinephrine and epinephrine have effects on alpha and beta receptors. Alright, so norepinephrine and epinephrine have effects on alpha and beta receptors. Now, the alpha-1 receptor is actually responsible for vascular smooth muscle contraction, which is why you actually get the hypertension with the pheochromocytoma. Now, alpha receptors have other things they do that includes pupillary dilator muscle contraction, which is why again sometimes people do have blurry vision with pheochromocytoma. And also it has effect on beta-1, which helps to increase heart rate and contractility. And so what are the symptoms we see with pheochromocytoma? Now, pheochromocytoma as a classic triad, which is episodic headache. So if you see it on examinations for the board exams, you're going to find a patient that's probably been having headaches. They might tell you sometimes patient has an history of migraine, but then this particular headache is just really, it's like very, very bad. It has not stopped. Medication has not helped it so far, like, the usual over-the-counter maybe the patient takes. Then also they have like this diaphoresis or excessive sweating and tachycardia. So these three are the classic triad for pheochromocytoma. So whenever you see these three, you have to assume it's pheochromocytoma, unless of course otherwise stated. So episodic headache, sweating, and tachycardia. Now, of course, other things you would see. Okay, so this is just to show you. So that's the headache right there. The drops are just kind of to refresh about the sweating and the tachycardia. Now, other signs and symptoms we see include hypertension, and we're talking about severe hypertension, where the patient goes to see the family care physician, and then they give the patient antihypertensive, and for whatever reason, the patient is still having like the high blood pressure. It just doesn't go down, right? So that should make you suspect pheochromocytoma. You also get palpitations. You just feel like the heart is racing fast. Also anxiety. Feeling of impending doom. Again, all of this should really tell you that your fight and flight is put into motion. There is lots of epinephrine and norepinephrine. That's be ready to fight, get active, that kind of stuff. And also the blurry vision. Now, how do we diagnose pheochromocytoma? Now, the initial test that many experts actually prefer is to check plasma metanephrine, and this is 96% sensitive and 85% specific. Another thing you can do to diagnose pheochromocytoma is to actually do a 24-hour urine collection for catecholamines and metanephrine. So when you see any of these options on your board exams, you can pick any of them. That is the initial test. Again, you don't treat a patient until you confirm. So let's say you have this woman who today is coming in with headache, high blood pressure. She's been to like 2 doctors. Everybody's giving her medication and it's just not going down. Some even probably diagnosed her with anxiety attack, and she just feels like, I'm not really feeling well. So when you see that kind of scenario, now the options might tell you, oh, you should treat or whatever. You cannot treat until you diagnose. So how do you diagnose? You should do urinary collection for catecholamines and metanephrine, and also plasma metanephrine testing. So any of this you actually see on exam, you can pick them. I've not seen an exam where both of them are in the option, but the best initial actually is the very first one, plasma metanephrine testing. Now, sometimes when you want to do the 24-hour urinary collection for catecholamines and metanephrine, you need to check that your patients are not using TCAs and over-the-counter decongestants, because they can actually increase the level of epinephrine and norepinephrine in blood. So they have to be stopped weeks before testing. Again, this is something the board exams can just pop up on you. So make sure that your patient is not taking TCA at the time of the testing or over-the-counter decongestants. Alright, so after we've done biochemical confirmation, the next thing is imaging. We need to know exactly, because remember we said 90% cases are adrenomedulla, but also it could be extra adrenal. So we need to confirm exactly where. So what are we going to do? We're going to do an abdominal CT scan, or sometimes you can even do an MRI. So abdominal CT and MRI are useful diagnosis. Again, that is after. So let's say you get an exam question and you suspect pheochromocytoma, right? They ask you, what is the best next step? Your answer cannot be CT scan. The answer has to be to check either the plasma metanephrine or urinary catecholamines, 24-hour urinary catecholamines. So make sure then after you've confirmed that, then you can do a CT, unless the veneer tells you that, testing showed elevated, urinary catecholamines. Then in that case, obviously your best next step would be to do a CT scan or an MRI. All right. So after we treat pheochromocytoma, the first thing is surgical However, pause. Before surgical removal, we need to give medications. Now, what medications do we give? We actually give medications that block alpha receptor and beta receptor. Now, don't just read your books like, oh, block alpha receptor and beta receptor. You have to remember that it is important to give alpha blockers first before you give beta blockers. Because when you give beta blockers first, what happens is that the alpha receptors become unopposed and your patient could literally go into hypertensive crisis. So we need to make sure that we actually do alpha blockade first. And what drug do we give? We give our patient phenoxybenzamine. And this is given 10 to 14 days before surgery. So we give phenoxybenzamine, which is an alpha blocker. Now, once we've achieved alpha blockade, then the next thing is we can now give beta blockers. Usually this is propranolol. So the beta blockers would help us to resolve the tachycardia, whereas the alpha blockage would help us with the hypertension. Alright guys, so that is it pretty much with that. And miscellaneous stuff is, well, just to kind of bring to your memory, because I know most of us are studying for exams. So adrenomedulla embryology is that it's derived from the neural crest cells, and adrenal cortex, which is different, right, comes from the mesoderm. So that's it guys. Thank you very much for listening. Please subscribe to my channel, and I'm going to bring you more exciting videos. Thank you.